Hello, good morning, everyone. Today's topic of discussion is external cervical root resorption, or simply known as external cervical resorption. Now, why we are doing this topic is that in the previous 4 to 5 years, um, this question has been repeatedly being asked in AIMS SR as well as PGI exams. So it becomes very important for all of you preparing for your INI CET, as well as secondarily important for your NEET exam as well. Now, very more specifically, what happened in PGI 2018, if we combine the June and the December PGI Chandigarh 2018 exams, then 3 questions simply from Hethersay's classification of external cervical resorption were asked. Now, if you knew it, you could answer it. If you had not memorized it, you would be found lacking. And it was unfortunate for all of those who just could not answer this, because frankly, as far as classifications are concerned, it's all memorization, it's all memory, it's all ratification, and there is hardly any concept to it. Anyways, let us first look at the question, and then let us have a brief discussion of external cervical resorption. And along with that, let us briefly discuss the various other types of root resorptions as well. Okay, so I'll be sharing the screen now. External cervical resorption. Screen sharing, I'll put it on the big screen mode. Yeah, I think we are ready to go. Okay, now the question was that invasive cervical resorption, which is a well-defined invasive resorptive lesion that has penetrated close to the coronal pulp chamber, but shows little or no extension into the radicular dentine, is classified as. Now, according to Hethersay's classification, the answer is simple. It's basically class 2, something that had to be memorized. So we just highlight it here, class 2, in which straight taken from the definition, well-defined invasive resorptive lesion that has penetrated close to the coronal pulp chamber here, okay, but with little or no extension into the radicular dentine. All right. Now, what happened in 2018 PGI was they also asked, as part of totally separate question, they asked class 3 also, and they asked class 4. So had to be memorized, could not help you with this. Now, let us try to make this extremely boring topic slightly interesting by incorporating concepts and trying to correlate and generalize it with other types of resorption. So we start with the basic classification of root resorption. Okay, let us look at this. If we try to classify root resorption, then it is of basically primarily of 2 types. One is physiologic, that is happening to all of us, right? There is no pathology involved. What is that? The classic example is exfoliation or shedding of primary teeth. Simple. Then we have the pathologic. Now, in the pathologic, we have, depending on what part of the root is being resorbed, whether the external surface is being resorbed or the internal root canal wall dentine is being resorbed, we have external root resorption and we have internal root resorption. Now, in external root resorption, we have further of 2 types. That's your external inflammatory root resorption, and we have what is our area of concern today, our topic of discussion today. We have the external cervical resorption. External cervical resorption. Okay, so this is where external cervical resorption fits into the larger classification or general scheme of things. All right, I hope this is clear. Now let us look at the histology part of any type of resorption of hard tissues of the human body. So the classic example that we study right from our anatomy is osteoclasts, which are resorbing the bone. And it has been now clearly demonstrated that whether we talk of osteoclasts on one hand, which resorb what? Which resorb bone, and odontoclasts, on the other hand, which resorb dental hard tissues. Okay, they are both derived from the macrophage monocyte lineage. In other words, they are very similar to the extent that some workers have said that they're actually the same. And how do they look like? They are nothing but multinuclear. They have a lot of, they're multinucleated cells. They're basically multinucleated, phagocytes, foreign body and inflamed tissue eating cells. And they have these projections when they attach to the mineralized substrate, that is mineralized bone or mineralized dentine or mineralized part of the cementum, they form these extensions, which is known as the ruffled border. Ruffled border, also known as the brush border, and these lacunae, these spaces in between these podosomes or these cytoplasmic extensions where the resorption is taking place. These lacunae or these spaces where the resorption is taking place are known as Hauschip's lacunae, right? That was our basic pathology. Now let us look at the dental perspective. What is most important to understand here is that would form the basis of our further discussion. What is most important to understand here is the fact that whether we're talking of odontoclast or osteoclast, obviously now we will restrict our discussion to odontoclasts, right? Because we're talking about tooth resorption. They can only bind to the mineralized tooth structure. They cannot bind to organic protein, to the organic proteinaceous covering of the cementum known as pre-cementum on the external root surface, and the organic proteinaceous covering of the dentinal wall on the internal root surface, that is known as predentine. So therefore, in the general scheme of things, when there is no trauma, there is no inflammation, there is no inciting assault or stimulus, root resorption does not take place normally. That is why it's a pathologic phenomenon. It takes place when this protective covering is disrupted by trauma. So that brings us to the next part, that is the Etio Pathogenesis. So I have this tooth, all right, which is covered with pre-cementum, right, all around the external surface, and internally it's the predentine. Whatever the case may be, if there is trauma, or if there is trauma, or there is this forces, excessive orthodontic forces, or there is pressure from cysts and tumors, right, or there is iatrogenic damage because of periodontal procedures, this pre-cementum layer, the continuity of this pre-cementum layer is disrupted. So the underlying mineralized tissue is exposed to be attached to the odontoclasts, which can now initiate the root resorption. So that's the first step. When you talk about etiopathogenesis, the first step is initiation of root resorption. Now, second most important point. The second most important point in the etiology is that for this to sustain, for the root resorption to sustain or perpetuate, there has to be a continuous source of irritation or inflammation. Now, that is provided by the infected root canal system. Infected, necrotic root canal system on the one hand, and secondly, it can also be provided by the presence of microorganisms in the gingival sulcus, right? So these 2 points are very important. If there is no infection, if there is no microorganisms which can sustain the inflammation and keep on recruiting via the host response, there will be upregulation of cytokines, the odontoclasts will be recruited, and they will keep up continuing their work of resorbing the tissue. If there are no microorganisms present, then this root resorption is completely self-limiting. It will stop on its own. All right. So that was the Etio Pathogenesis part. In general, this was talking of all types of pathologic root resorption in general. Now, our discussion is now more specifically related to external cervical resorption. Let us just briefly see why is it known as external cervical resorption? Because number one, external, it's taking place on the surface of the root. Number 1 point, right? That is done. Cervical, because it's taking place in the cervical area of the root. Now, normally that is what happens, but more specifically, it's actually not necessarily the cervical area. It's the place where this resorption starts is just apical to the junctional epithelium. Now, junctional epithelium, just apical to it, is the cervical area. But what about teeth which are suffering from gingival recession? Old patients suffering from gingival recession, there the starting point of the external cervical resorption will be more apical. Okay, so that point is clear. Etio Pathogenesis. Etio Pathogenesis, as we already discussed, 2 points have to be discussed. One is the initiation. So what is the initiation? Most common initiating factor is the orthodontic treatment. The pressure due to sustained orthodontic treatment. Second most important, dental trauma. Third most important, bleaching of teeth. Right? These are the 3 most important initiating factors. Now, what is the factor which would sustain the root resorption? Right? So, initiating factor was the factor which actually did what? It damaged the pre-cementum. Okay. And what is where will the microorganism come from which will sustain this inflammation? That would be microorganisms from the gingival sulcus. Now here, I would just like to mention one more point, that according to Hethase, he said that forget about microorganisms. It's the external cervical resorption is actually a totally separate entity. It is nothing but a benign fibrovascular proliferative lesion with no significant involvement of microorganisms. Anyways, there is no final verdict as to who is right. Okay, so that discussion remains open. We just have to be sensitized about these points. Okay, next important point, histology. What is the histology? What is the important points in the histology of external cervical resorption? One is common, that is your odontoclasts will come, right? So that's your cell, that's your odontoclast. It would expose these, take out these photosomes, the cytoplasmic extensions, form this ruffled border in the Hauschips lacuna is the site where the root resorption will take place. Fine. What is the next important point? In these resorptive defects, in this resorptive defect, there will be the presence of fibrovascular tissue. This is nothing but granulation tissue. All right. That's point number 1. Second important point from the histology part. What is the histology of the associated pulp, of the subjacent root canal system pulp? Now, normally in the initial and the middle stages, the assault on the pulp is not there. Why? Because the pulp space is bordered by what? Is bordered by predentine, and predentine is an organic covering, and organic covering, odontoclasts won't attach to it. So therefore, initially and in the middle stages also, the root canal space will be absolutely normal. It's only when it just completely goes untreated for years, and the resorptive defect, it finally invades in the later stages, in the last stages. it finally invades the root canal system, and the root canal system ultimately turns necrotic. So these are the two things. One situation in which root canal system is not involved, the other situation in which the root canal system is involved. Okay. Then what are the clinical features? First, mostly it is asymptomatic because the pulp is not involved, right? So there is no pain. It's asymptomatic. Because of the proliferation in the cervical area, yes, there might be some bleeding on, toothbrushing and bleeding on, any external trauma. That's separate. Second, so it is what? It is basically, how is it diagnosed? Either as a pink spot in the cervical area, which the patient or the clinician sees, or it's a chance discovery on routine radiographs. All right. In the later stages, when the pulp space, late stages, when the pulp canal or the root canal is involved, then obviously the tooth becomes necrotic. There'll be a apical periodontitis. There'll be a chronic abscess. There'll be sinus tract. There might be buccal space infection, tissue space infection, facial space infection, etc., etc. That obviously will happen if it goes undetected and untreated for prolonged period of time. Then what are the radiographic features? Very interesting. Let us just use a highlighter to understand the radiographic features. Initial stages, it's totally radiolucent. Why? Because the tissue is fibrovascular. Then the body starts to deposit osseous tissue in response. So the radiographic appearance becomes cloudy because of osseous inclusions. Then in the later stages, there is more radiopacity. So the radiograph appears mottled. Then next important point, what about the margins? Margins are they can be irregular, poorly defined to well-defined also. Well-defined margins can also be there. So that, again, we have the entire, spectrum. Then what about the root canal outline? In the initial and the middle stages, the root canal outline is completely separate, continuous, right? There is no breach in the root canal outline, even when you change the horizontal angulation of the X-ray. But in the later stages, when the root canal is involved, then obviously, it's very tough to differentiate between external cervical resorption and internal resorption, because then there'll be, the root canal will be continuous with this ballooning effect, this sudden enlargement in the cervical resorptive area. What is the management? Management is excavate the resorptive tissue. This fibrovascular, fibro-osseous tissue has to be excavated. So you have to raise the mucoperiosteal flap because it's present just apical to the junctional epithelium. So raise the flap, excavate it out, and then restore it. Restore it with GIC composite. But obviously nowadays, the material of choice would be something like a biodentine. Why? Because it's aesthetic also. At the same time, very biocompatible, very good reattachment of junctional epithelium takes place on its surface. So that becomes the material of choice, better than GIC and composite. Now, if this resorptive lesion is diagnosed at a later stage, where it has already communicated with the root canal, then you have to perform RCT also, because then you have to prevent apical periodontitis or treat it if it is present. Okay, then the next important question is, what is the role of 90% TCA? Now, TCA is trichloroacetic acid. What it does is that even when you have surgically, raised the mucoperiosteal flap, excavated the fibrovascular tissue, some remnants, some channels of resorptive tissue might be present. So then you apply 90% TCA, right? What it does is it burns, it completely causes coagulative necrosis of the remaining remnants of the resorptive tissue. Okay. And that helps in complete removal of the resorptive tissue. All right. So this was a brief discussion on external cervical resorption and the associated MCQs that come. Thank you very much for listening.